Morning everyone, welcome to today's webinar, which is aimed to provide an overview of the COVID-19 residential aged care facilities outbreak response plan run by WA Health. My name is Kylie Mulcahy. I'm here from the State Health Incident Coordination Centre, and it's my pleasure to facilitate today's session. Thank you all for joining us. I'd like to start by acknowledging the traditional owners of the land and the airwaves in which we're meeting today, the Whadjuk people of the proud Noongar Nation, and pay my respects to elders past, present and emerging. As everyone is well aware by now, the Government of Western Australia has declared a state of emergency and a public health emergency in response to the COVID-19 pandemic outbreak. Globally, as of yesterday, there's been over 15 million confirmed cases of COVID-19, sadly including over 600,000 deaths reported to the World Health Organization. So whilst we continue to see a small amount of new cases in WA, it's important that we do have the right plans in place to allow us to quickly adapt to changing circumstances as our understanding of COVID changes over time. So with that in mind, I'd like to introduce today's panel. We've got Dr. Andy Robertson, our Chief Health Officer, myself, Gail Milner, who's leading the COVID-19 aged care response for WA Health, and Dr. Robin Lawrence, our State Health Incident Controller. The panel will talk through over the next hour the plans that we've got in place, and there will be opportunity for questions through the chat function, which you're welcome to use as well. Just to note that obviously the information we're providing today is as up to date as we know it at this minute, but that it does continually change over time. So just keep that in mind, and we'll provide some ways for you to stay up to date at the end of the webinar. With that, I will hand over to Andy to provide an update on the current state of WA and the role of public health. Thanks, Andy.
Good morning. There is a presentation that will come up. We might just move to the first slide. Okay, might move. So I'm Dr. Andy Robertson. I'm the Chief Health Officer, and I'm also the Delegated Hazard Management Agency for this pandemic. Next slide, please. So if we look firstly at WA, we've had no new cases yesterday. Our state total remains at 654. We've actually had no active cases in the last 5 days, and all of our cases have either been historical cases or cases within hotel quarantine for some considerable period of time. We have no confirmed cases within in our Perth hospitals. We have had, unfortunately, 9 deaths, but they were from earlier on during the pandemic. We have 14 active cases. Again, they are primarily in our hotel quarantine, and we continue to test. We do about approximately, between ourselves, the public and the private, we do around 2,500 to 3,000 tests a day, and we're currently at nearly 233,000 tests have been done in Western Australia. Next slide, please. As Kylie pointed out, the situation continues to deteriorate around the world. As of yesterday, over 15.2 million confirmed cases, primarily in USA, Brazil, India and Russia at this stage, but it's obviously picking up in other parts of the world, and over 623,000 deaths reported so far. And noting that in places like India, that's probably a serious underreporting of deaths and probably of cases as well. In Australia, as of yesterday, we had 13,306 confirmed and probable cases. 103 deaths. That's jumped up in the last month from about 102 in 16th of June. It was around 102 to 133. Total number of cases over the last 7 days was 2,509 cases. And 2,388 of those cases were in Victoria. Just to put that in context, 106 in New South Wales, and 8 in WA. All of our cases were from, 7 of those 8 cases were in hotel quarantine. 1 was in a returned person from Victoria. These are the national statistics from yesterday. This gives you an idea of where we're at from new cases. So I think you can probably appreciate that we are, this is primarily, these numbers are coming from Victoria with a small sprinkling from New South Wales and other states. But as you can appreciate from that, this is very much a serious second wave that's occurring in Victoria, and we're still unclear as to whether we're at the peak of that wave or whether it has some way to run, and we'll have a better idea of that over the next 1 to 2 weeks. Next slide, please. This gives an idea of this is the number of cases. This is a logarithmic scale, so number of cases. You'll notice Australia had been relatively flat until recently. Unfortunately, I think we're now on the way up, and we'll soon cross the figure for South Korea. But you'll see that the US, Brazil, India, and I don't think Russia's on that map, remain the areas of concern around the world. Sweden, interesting to see there, which is often one of the examples of mooted herd immunity, is obviously continues to rise. Next slide, please. It's not all bad news. This is a slide of influenza notifications. This is from January to June. It hasn't actually changed, but what we've seen is almost no. We've had one case in the last 10 weeks of true influenza. So it has to. This is way better than normally we'd see it in summer, let alone in winter. So we've actually had a lot. Had basically no flu season, and subsequently, given that we had 80 deaths last year, there's probably been a number of deaths that have been avoided. Next slide, please. And this continues on. This is one of our reports on winter respiratory illness. So we are seeing very low levels of admissions for any winter respiratory illness. So that again is also good news, and that continues on. This is from June, but it's continued on through July. Just to talk a little bit about the role of FEOC, so that sets the scene. Just a bit on the governance. From a national point of view, this is being managed under the Biosecurity Act and the National Health Security Act. The Australian government, from a health point of view, the main advisory committee is the Australian Health Protection Principal Committee. That is a subcommittee of National Cabinet. Next slide, please. It has memberships from chief health officers from each of the jurisdictions, and it's chaired by the chief medical officer from the Commonwealth Department of Health. It has met daily for about the last 6 months, and it works together to produce an coordinated evidence-based response in Australia. It is the main public health advisory committee up to National Cabinet, and you will have seen a number of the advice that has been put out, including in the aged care arena. And it is informed by a number of subcommittees in communicable disease, public health laboratories, and infection control. And it updates the requirements regularly. From a state point of view, this is managed under both the Public Health and the Emergency Management Act. State Hazard Plan was escalated back in early March. We moved to a state of emergency in mid-March, both from under the Emergency Management and the Public Health Acts. Next slide, please. This is some of the legislation, and these are the acts, primarily the Public Health Act and the Emergency Management Act. And obviously, Department of Health has a lead agency, but as does the Police Commissioner, and Police, as he is the State Emergency Coordinator, so we work very closely with police in this space. And then obviously we work very closely with our health service providers and the general health sector, and part of this is part of the discussion today. Next slide. So my role is to inform and lead. So the health response is informed and led by the Chief Health Officer. obviously by the Public Health Emergency Operations Centre, and I'll mention a bit more about that, and the State Health Incident Coordination Centre, which is run by the State Health Incident Controller, which is Dr. Robin Lawrence, who will give a presentation on that. We obviously work very closely with other state and federal government agencies. We've worked closely with them throughout this, and that includes Defence. But just going on to FEOC's responsible for leading the public health response, and I'll go into that in further detail. And then SHIC commands and coordinates all of the health resources for responding to the impact and effects of a major incident, and I'm sure Robin will go into detail on that. This is a very early one. I think that this is coming actually from February, but it largely picks out just the broad governance structure. What it doesn't show is there's obviously we report up to the State Emergency Coordinator and the whole apparatus that sits under police. But it does show that both the two sort of arms, one around the public health side, the other one around the more broader health capacity, health system side. Next slide, please. This is in a bit more detail. Nobody's going to be able to read this slide, I'm sure, but it just highlights about the structure, where it reports up to. Obviously, the Director General is the Hazard Management Agency, which is delegated to my role, but then the Incident Controller, which is Dr. Lawrence, and then the FEOC, which is run by Dr. Armstrong, report up into those positions, and then their structures that sit underneath them. Next slide, please. So FEOC is the Public Health Emergency Operations Centre. It's activated to address the public health components of the response. So that includes things like the testing and management of suspected cases, and that also includes the contact tracing of those cases. We're providing, there's not a lot of work in that area for us at the moment, but we are providing support to Victoria to help them with identifying and contact tracing their cases. Obviously, the public health messaging and communications, the screening and isolation of people, so within quarantine and isolation of cases, border arrangements. FEOC was very heavily involved in a number of the cruise ships and other ship involvements, and managing those as they came through. And then the generalised surveillance of what's actually happening across the system and ensuring we have the data to indicate whether there is any cases within the community or any community spread. Just to give you an example, this is the FEOC, the human coronavirus pandemic potential, was declared a notifiable disease back in January. A lot of their role is to follow up the cases and their contacts. FEOC also has responsibility under the Human Biosecurity Act to implement border controls and to work with border agencies to make sure that that is robust. We obviously works closely with our public health lab testing capacity at Nedlands, which does a lot of the testing. It's got a turnaround time of around 8 hours from specimen arrival. It's involved in planning and programming for testing going forward. I mentioned about surveillance systems. A lot of the data that you see is requirement and is produced by this area, and they do a lot of the epidemiology. And then obviously there's quite an element of public health communication and getting the messages across. They also, as does SHIC, inform me as to what the situation is, and that obviously is used to inform government as to what measures should be taken or either eased or gone. Next, please. Just a quick one. Obviously, The COVID clinics continue to operate. Numbers are reasonably stable. We saw, I think, around 700 people presented at the clinic yesterday. We're still doing about 2,700 tests a day. And that's also being provided by both public and private pathology. Obviously, contact tracing continues. A lot of work going in readiness and surge, and I'm sure Dr. Lawrence will go into our preparations for surge. Quite a bit of work with business continuity in WACS and other areas. A lot of work on preparing plans for standing up facilities, standing up surge capacity, and obviously continue to work on other planning around patient transport and fatality contingency. But a lot of that will be, particularly for the aged care sector, will be addressed later in the presentation. I think that's probably it. Next slide, please. Questions? I assume we're going straight.
That's great. Yeah, we'll hold on the questions. We do have that chat function available. I can't see any coming through just yet, but you're welcome to fire any through. Thank you, Andy, for your time. We know you're very busy, and we send your apologies to the group. I know you have to head off a bit early, so appreciate that, and we will follow through with any questions that come up. Thanks to the team. It's really important to understand a bit more about that public health response and how important that is. Thank you very much for your time. Okay, I'd like to hand over to Robin Lawrence now, who's going to talk through a bit more about the role of the State Health Incident Coordination Centre. Thanks, Robin. Thanks. No, this is go. Robin's just going to chat.
I'm just going to chat.
I'm going to chat as well.
And now Andy's gone, so he's stolen most of my thunder, which is fine because that leaves more time for questions at the end. Good morning, everybody. Look, I think Andy's taken you through the high level of what the SHIC does when he articulated that we command and coordinate the use of all health resources within WA for the purposes of responding to the major incident or disaster, which in this case is clearly COVID-19. He mentioned that WA Health is the hazard management agency. Essentially, that is the Director General, and he delegates that to Andy, and then myself as the incident controller actually enable that to occur. The big overarching document that we follow in a pandemic is the State Hazard Plan for Human Biosecurity. And that is available on the web. You can have a look at it at your leisure, but it lays out how we respond to one of these incidents. And it lays out in that response about kind of steps which are engaged with and the relationship with the State Emergency Coordinator. But it enables the things that Andy's already talked about, such as arranging on the treatment and isolation of cases, conducting the testing, tracing and quarantine of contacts. And you can start to see already the massive overlap and the interrelationship that is really critical between the FEOC and the SHIC. Essentially, we are two arms of the one business operating, even though we've got two different names. We also advise on and institute infection control measures, and we leave that to the public health experts, predominantly in the SHIC, because that is not my area of expertise, but we coordinate and liaise to make sure those who need that resource can get access to it. And in particular, where we are quarantining people and providing advice to those in home quarantine or self-isolation, that they understand what that means. We work with local health service providers, both public and private, general practitioners, allied health, all affiliated health type services in the response. Obviously provide ongoing briefings up to the Director General and whoever else needs them, and work with the media. So what does that really mean? That means that actually we spend about 50% of our time fighting small fires and 50% of our time doing overarching planning. And whilst we'd like to think that planning comes to an end, as you know, it never does, because currently things are changing on a daily basis around the world, which is good because it gives us a lot of opportunity to learn and refine things and to take actions that we may not have known were needed. And Victoria's provided a great number of examples around this, where there were things that we suspected may be the case in an environment where you had widespread community transmission, and they have come to fruition, and some of those are running through the media, so we can discuss them, such as the issues which actually will confront some of your workforce, that some of the people continue to go to work and do normal things because they don't believe they can afford not to because of the casualisation of workforces in some areas. And it's quite widespread. It's not just related to aged care. It's going to be a factor in hospitals where we do use agency staff. It's a factor in meatworks. It's a factor in security companies. It's actually a factor right across our community, much more widely than we would have thought or anticipated unless you had stopped to think about it broadly. So having a mechanism that facilitates people not to be in that scenario by having funding available is the mechanism that Victoria had taken, and we had already started to explore that before it became really clear that that's what you needed to have in place. So that was one place where we were able to be ahead of the curve and say, look, we think we're going to need this, and we've already started the work, and that has been confirmed that that was a good thing to do. On the other side, we've learned a lot of other lessons about timing and the criticality of that timing. Again, theoretically, our public health experts would tell us those sorts of things, that the timing from a person becoming symptomatic to them isolating themselves, to them getting tested, to them getting a result, to contacts being traced is absolutely critical. And where that doesn't happen, you can see the outcome. It's much, much harder to get I guess, an outbreak under control without that timeline being as short as possible. And compliance. I think we all wondered what would happen with compliance with a second outbreak or a second wave, even though we never really had a first wave, given the community had responded very positively to the lockdown during our first wave across the country. We did wonder whether if you ever had to do it again, would you get the same compliance? And there's a suspicion, though I think it's far from proven, that the compliance in Victoria is probably less than what they had during the first lockdown because people are over it. Part of our role in SHIC is also to look at the way we do things in a more holistic view, because whilst we are the hazard management agency and the focus is on health, every health action has a consequence, and we need to be able to provide that relevant advice about what actions should be taken and what potential impacts should be considered alongside of those. And government then needs to weigh those up, and in particular the health impacts or benefits from a particular restriction versus the economic risk or benefit from that particular restriction. And obviously the overarching preference is that you put restrictions in place that have the greatest health benefits with the least economic impacts. Now clearly those two don't sit comfortably together. Only time will tell whether the restrictions have been put in place in the right order, in the right way, and whether as a global community we've made the right decisions around some of these things. So part of people's issues around confusion around what should be done, and last time we did this and this time we're doing something different, is related to that evidence as it comes to be understood and seen around the globe. So a big part of our job is actually keeping track of what is going on globally, together with FEOC, who have good links internationally through formal channels, but also tracking the informal channels so that we can continue to have those inputs into the decision making locally. We have a multi-agency team in SHIC, and that's really critical because obviously health alone cannot control this pandemic. It does require a multi-agency, both public and private and not-for-profit sector right across Western Australia to be able to deliver what the community needs and desires in this outcome. So by having people within the team from outside of health, we bring in skills that we don't ordinarily have or don't have in large supply within health. We also have greater channels to disseminate that work as it goes back out and a much greater understanding. I think one of the things we've seen is absolutely key is that cross-pollination of ideas and skill sets within the SHIC, and it's something we've continued to drive. The SHIC, as you saw on the chart, is made up of a number of cells. They are standard emergency management preparation cells. We have planning, which was split into, sorry, I'll go back. FEOC also has similar aligned cells, so they have their own planning structures. But we have planning, we have health ops and non-health ops, and that really is just to share the workload. Within our non-health ops, a very big piece of that work links to the borders, and that is our quarantine management that is done within the hotel sector. for both international and now a range of interstate arrivals going into those facilities. And that is a massive logistical operation requiring both general logistics, hotels, food, security, as well as clinical support for that group. We then have a logistics cell, we have an intelligence cell, and that's essentially it, I think.
Public communications.
Comms, thank you. So that's essentially a high level overview of what we do. We do a lot of briefings up to government and to other organisations, webinars such as this, trying to work with as many people so we can get as much information out as possible. But I might hand back to Kylie and Gail to work you through the meat of the topic.
That's great, thank you, Robin. Just before we get into the residential aged care facility outbreak plan itself, I'll just give you a brief overview as lead of the planning cell around some of the other activities that we have underway. So certainly the cell's been very dynamic over the last couple of months and picking up hot issues and planning requirements as things change, and will continue to change over time, like Robin mentioned. So the plans that we have in place today will continue to be reviewed and regularly updated as new information comes to light. So we do have a suite of integrated outbreak response plans that have been developed to set up the state's strategic response to the outbreak, so at a state level and in particular high-risk settings, including aged care facilities. So we have an overarching integrated plan for the state that recognises the need for this integrated public health advice and the clinical, operational and then interagency responses to inform the overall incident response, just like Robin has outlined. So I did want to acknowledge that, and I think I can see 93 attendees online at the moment. Your own organisations will have an extensive portfolio of local and regional plans and responses. So our plans are there to support at the state and system level. The principles in our plans are to ensure a graduated and proportionate response that's coordinated and integrated, to enable the activation of that system level response when it's needed through the SHIC, so that it can be scaled when the ability to manage locally is exceeded. And also the plans aim to really clarify the roles and responsibilities, which is the key part to having an effective response. Whilst the plans address the current state in WA, the phases, principles, strategies and considerations all described are scalable. So if we do get a geographic cluster or clusters that are not containable or we have widespread community transmission that's occurring, they can be scaled to that degree. So as well as the aged care plan, which you'll be quite familiar with by the end of today's session, just for information, we also have a prison outbreak response plan, hospital outbreak response plan, one for schools and childcare services, mining and offshore facilities, commercial vessels, congregate living, and also remote Aboriginal community plan too. So just to assure you, there's a suite that we are working hard on. I will hand over to Gail to run through the specifics of why we're all here today for residential aged care. Thank you, Gail.
Thank you, Kylie. I'd just like to say a big thank you to those participants online in RACFs that have contributed to the development of this first version of the plan. It might be the first version, but I can assure you there were many drafts along the way. Okay. The outbreak response plan is really quite tailored to RACFs, and it's about informing a multi-agency response within the RACF. But I just need to reassure you that this plan doesn't replace your local outbreak plans. The idea is it's supposed to complement and reflect the hierarchy of local, regional and different agency plans. As you'd be aware, RACFs have a very specific definition of an outbreak, which is the single confirmed case, either resident, staff member or frequent visitor. And the Communicable Disease Network Australia has defined that because RACFs are considered to be a very high risk setting due to the comorbidity and age of the residents that are living in such a facility. Okay. The next slide is roles and responsibilities, and when you do read the plan, there is a lot more detail around this, but this is just a quick ready reckoner about roles and responsibilities. And very clearly, the RACF leads and manages the outbreak, and both Commonwealth, state and different agencies are there to support the RACF to manage this response. It's been very valuable, the time we've gained in WA, because different pieces of structure are being provided, particularly through both the Commonwealth and the state government, about how to manage in a facility. There's extensive information about PPE, what to do in the first 24 hours in a Commonwealth facility, and what the Safety and Quality Commission and what their role is. Okay. In the plan, you can see there are 5 phases. We're currently in we've completed phase 1, and that's just ongoing about outbreak prevention and preparedness. And that's really the plans that you've developed around workforce, supply management, and how to promote and support infectious prevention and control. Phase 2 is our standby, and this is where, particularly from the state and the Commonwealth, we're supporting agencies in the development of plans. We're also into testing and isolation. Phase 3 and 4, which is the outbreak response, and I think that's probably generated the most interest from RACFs, is about actually who does what and what do you do when there's a definition of an outbreak. And that really is your outbreak management teams, the public health role about case management and contact tracing, and then what the expectations are of the outbreak management team. And the plan goes into that into some detail. Often phases 3 and 4 are combined because they need to represent a rapid multi-agency response that would occur from the outset of an RACF. And phase 5 is really important. That's about outbreak recovery. We do understand that RACFs have to, at the same time, have business as usual, but also about how you go forward when the outbreak is over. I'll just go through a little bit of the detailed headings about phase 1. I understand all RACFs have an outbreak plan, and the Commonwealth has been very instrumental in ensuring that this has happened. I know that includes staff contingency planning of up to 30 to 40% of staff not being available. There's been considerable effort in education and training, particularly around infection prevention and control and PPE. Facilities have been certainly ensuring that they have sufficient stock of PPE, and I know at times that hasn't been easy. Ensuring that they've got a continual supply of linen and meals and all other pieces of either equipment or services that you would need, and that there's been quite a lot of work around developing communication tools. And there's quite a specific role in the plan about how SHIC works together with FEOC and the facility about communicating both with the Commonwealth, with the state, with premiers, with families, and particularly the media. And sometimes the media have been quite difficult to manage. We often know that they're quite sensationalist at times, and that's not always been to the benefit of us all. The next phase is the outbreak standby and monitoring, and that's really around notification and organising of testing and the notification to FEOC and SHIC, and also the isolation of suspected cases. And this isolation has often been of concern, particularly if you're looking at a workforce. And I think from Robin's comment that's come out of Victoria, that once you've had a swab, you actually need to isolate. And I have heard of instances of people maybe sometimes delaying having a swab because they know the consequence of isolation. But I think the Victoria second wave is telling us that you really do need to isolate once you've been swabbed. Phase 3 and 4 is where we see a lot of action, from rapid escalation to really quite targeted action. And that's the confirmation of the cases, FEOC's role about case management and contact tracing, isolation. And we talk about the medical care of residents, the support of a clinical and logistical support team that would be authorised through SHIP to support an RACF, and that team consists of infectious disease, physician, infection control, nursing staff. We talk about hospital transfer for clinical care. Residents in facilities, if they require clinical care in a hospital, will be transported. We talk about control strategies and visitor restrictions, and that's been quite a difficult area and has caused a lot of media concern. The importance of mental health and communications with residents, staff and family, and managing the media. And phase 5 is, to determine that the outbreak is over. That decision is made with FEOC and the Chief Health Officer. Then the returning to business as usual. The debriefing and closing out, and what lessons learned that can be incorporated in your business continuity plans if you've had an outbreak. The last slide is just some actions that I think it's worthwhile for RACFs to think about going forward. And that's revising and testing your own outbreak plans and having that scenario testing. And often when we've done it here in health, you identify the gaps. It's not a test per se, it's there to provide an opportunity to learn. One of the matters that Robin has mentioned before is accessible site plans, the architectural plans, which are useful, how the building is laid out. Have you thought about isolation and cohorting, what that would look like? In the plan, there's a FEOC assessment criteria. Have you made an attempt to complete that, and is it available? A line listing template, which is often referred to in the CDNA guidelines that FEOC will want. And that's really about place, person and test results, that information. Have you got a communication plan for residents, family, and drafted some media statements? A resident profile, is that readily available for residents so decisions and determinations can be made at the facility? Keeping in constant contact and having GP information available. And have you got a laboratory testing pathway already established? These are just some thoughts about how you can anticipate moving forward in your planning. I'm happy to support different RACF facilities, and I might work through the peaks as well about how we can, do the next lot of steps in preparation, because it's great to have a plan, but you really need to test the plan and have you got these extra pieces of information, because if there is an outbreak or when there is an outbreak, it'll be a bit late to be doing this then. You really want to have been prepared. That's all from me. Kylie, thank you.
Great, thank you, Gail. Now, I understand, unfortunately, the chat function is not working as it's currently set up. The gremlins are back. So we did have some time for questions. I do have a couple of questions lined up from some of the hot topics that we've experienced over the last couple of months. So I might start with one for Robin, if it's not. We're going to try and end the slideshow and see if that helps. We'll try not to end a live event at the same time. That would be great. Okay. So, Robin, something that's come up through a number of the stakeholder forums and things that we've had over the last couple of months is around asymptomatic testing. Would you like to talk about asymptomatic testing?
I'm going to start by saying I'm not the public health physician, so I'm not an expert in this area, but we've all had to learn very quickly around this. One of the lessons coming out from Victoria is asymptomatic testing in an unstructured way has very little role to play. And in fact, all it does is use resources that are required in an outbreak. So at this point, the stance on asymptomatic testing absolutely has not changed, in that random asymptomatic testing has no role. Targeted asymptomatic testing in an outbreak may well be a different scenario and would always be done on public health advice. And of course, where there are now close contacts of people who have already tested positive, those people are being tested asymptomatically because they are a much higher risk, and that gives you the ability to ensure that people who are contacts haven't picked up asymptomatic disease. And we are, of course, doing asymptomatic testing on high risk international and interstate arrivals. And we do pick up some asymptomatic cases in the international arrivals. We haven't obviously detected any in interstate arrivals at this point that are asymptomatic. However, there is no doubt that testing even mildly symptomatic people does have value. In an outbreak, I think we've already seen, we've done it in our cruise ships, and it will happen in aged care, that where there is an outbreak, you almost certainly will go through and you would test the entire facility where there's crossover of people who may well have been able to spread the disease. So random asymptomatic testing out, very targeted asymptomatic testing under the guidance of public health does have value.
Great, thank you. Gail, I'm going to turn to you for this one. I know early on the availability of personal protective equipment and other supplies was an issue. In residential aged care facilities, what support will be available in terms of PPE if it's required?
I think we refer back to the Commonwealth email address in which supplies can be sourced, and the way they are sourced is the Commonwealth advises the state office, and the state office delivers those. Sometimes we've had PPE delivered within 4 hours, and particularly also a very short turnaround in the country. So I know that system is working. However, if there is anybody who is having a problem, let us know, and I'll work with my Commonwealth counterpart to see what we can do. But they've done a lot of work in that area to ensure PPE is available.
Great, thank you. In terms of positive COVID cases being cared for in residential aged care facilities, if and when would a patient be transferred to a hospital scenario?
I think Robin's answered this very well when we met before. Anybody who has a clinical need to go to hospital will be transferred to hospital. And it really is a case-by-case basis when the team gets to a facility and how it's being managed, if there are any other accommodation options that need to be explored. But we don't have a blanket, everybody will go to hospital like South Australia. Clinically indicated, you will go to hospital, and then it'll be a case-by-case at that facility when FEOC and SHIC do an assessment. I think that's fairly well where we've landed.
Yeah, exactly. And I think what you can see in Victoria was if you had to transfer every person who had COVID from a residential aged care facility to a hospital, you would very rapidly overwhelm the healthcare system. Therefore, it will be people who need hospital accommodation and treatment will be transferred to hospitals. If we need alternative accommodation because the facility is not suitable for isolation, that's a completely different discussion and scenario which will be supported under the guidance of FEOC.
Thank you both. Apologies again that the chat function still doesn't seem to be working, but we would like to take your questions offline. So there is a COVID planning email address, which is COVID planning, PLANNING at health.wa.gov.au. So any questions that we haven't answered in this session today, you're welcome to contact the team and we'll try and get you a response.
Kylie, can I just one other really important thing, sorry, before I let Kylie kind of close out, in that the issue of mobile staff is proving to be really problematic across several industries in Victoria. So it's not just that they're casual and that they can't afford to work, but the fact that staff in hospitality, to a certain extent in retail, aged care, meat works and a number of other industries work between multiple locations has enabled the disease to spread more rapidly than what you would see in a workplace where you have a designated office team coming to the same office every day. So where you've got capability to work either as a big group of aged care facilities or to pull together to work out how you can minimise staff movement with your casual and your agency workforce, recognising you can never eradicate it in our business. We know that, but where you can minimise it, please be focused on having a plan around that and implementing it now, because once that horse is bolted, there's no pulling it back. So that is another thing I'd be adding to your list. If you haven't done it, please look at how you can work either within your group of aged care facilities or with other small providers if you aren't big enough to do that, as to how you can minimise that workforce being really very mobile.
Great. Thanks everyone. We will close up there. I'd like to again thank our panel for the time it's taken to prepare for this. There is a lot of stuff that happens in the background for these events, so we hope it's been useful. As mentioned, you're welcome to email the covidplanning@health.wa.gov.au email address if you have any further questions for the team. And thank you. Enjoy the rest of your days.